Imagine being told over and over again to just focus, just sit still, just try harder. But what if your brain simply works differently? For millions of people living with ADHD, this is their everyday reality. Understanding how and why isn't just science. It's the foundation of compassionate, effective care. ADHD is a neurodevelopmental disorder affecting executive functioning. This means attention, impulse control, planning, and organization. These are not behavioral choices. They reflect altered dopamine and norepinephrine signaling in the brain regions responsible for cognitive control. Current guidelines recommend stimulants as first-line treatment, with non-stimulants used when stimulants are contraindicated or just not tolerated. By the end of this video, you will understand exactly why, down to the synapse level. ADHD does not look the same in every patient, and that matters clinically. Some individuals primarily struggle with sustaining attention and following through, even when they are genuinely trying. Others present with marked hyperactivity, impulsivity, and difficulty staying still. Many show a combination of both. Recognizing the presentation shapes both treatment selection and nursing assessment. But to understand why any of these treatments work, we need to go deeper into the brain itself. Here's what is actually happening neurologically, and once you see it, the medications make complete sense. The prefrontal cortex is the brain's control center. It filters distractions, regulates impulses, and drives decision-making. In ADHD, signaling here is inefficient, and that inefficiency reduces the brain's ability to sustain attention and regulate behavior. This is not a peripheral issue. It is the core of the disorder, and it does not work alone. Deeper brain structures are involved too. Deeper in the brain, the basal ganglia and striatum coordinate movement, motivation, and behavioral reinforcement. Dopamine disruption within these frontostriatal circuits contributes to hyperactivity and difficulty sustaining goal-directed behavior. When signaling is underactive, behavioral regulation breaks down. So what is actually driving that disruption? The answer is at the chemical level, and that is exactly where we are going next. Here's where things get interesting. Neurons communicate by releasing neurotransmitters into the synaptic cleft, where they bind to receptors on the next neuron. The strength and duration of that signal, how long those neurotransmitters stay active, directly determines how well attention is maintained. In a healthy brain, this process is timed perfectly. In ADHD, something goes wrong, and we are about to see exactly what. Two neurotransmitters are at the center of this. Dopamine supports motivation, reward-based learning, and task prioritization. It helps the brain decide what is worth focusing on. Norepinephrine drives sustained alertness and impulse regulation. When these systems are underactive or cleared too quickly from the synapse, focus becomes inconsistent and executive function suffers. In a healthy system, dopamine and norepinephrine are released, cross the synaptic cleft, and bind to postsynaptic receptors. A portion is then reabsorbed through reuptake transporters, a regulated process that maintains signaling balance and prevents overstimulation. The key word is regulated. The timing of reuptake is what keeps the system working properly. In ADHD, the issue is not necessarily reduced production, it is accelerated clearance. Reuptake removes dopamine and norepinephrine from the cleft too quickly, delivering a weaker, shorter signal to the postsynaptic neuron. The prefrontal cortex does not receive the sustained input it needs, and that is where attention and behavioral regulation begin to break down. This is the mechanism. Medications target reuptake and transporters to increase the availability of dopamine and norepinephrine in the synapse. By slowing reabsorption, the signal remains active longer, strengthening communication within the prefrontal cortex and improving attention, impulse control, and executive function. Because of this mechanism, stimulants are considered first-line therapy in most clinical treatment guidelines. Stimulants increase neurotransmitter availability through transporter blockage, and in some cases, enhanced release. Nonstimulants primarily target norepinephrine and do not activate dopamine reward pathways, which is exactly why they carry a lower risk of misuse. That one distinction explains the difference in potency, onset, and abuse potential between these two classes. Now let's meet the medications. I chose 4 prototype medications, 2 stimulants and 2 non-stimulants. Methylphenidate, known by the brand name Ritalin, blocks the reuptake of dopamine and norepinephrine into the presynaptic neuron. By preventing rapid clearance, more of both neurotransmitters remain active in the synaptic cleft, strengthening the signal to the prefrontal cortex and improving the brain's ability to sustain focus. Methylphenidate is approved for ages 6 and older, but is contraindicated with MAOI use and in patients with structural cardiac abnormalities or arrhythmias. Serious adverse effects include sudden death, stroke, and MI, most commonly seen in those with underlying cardiac conditions. Expect headache, insomnia, and decreased appetite as well. Nursing priorities include establishing baseline vitals, monitoring BP and heart rate, tracking growth in pediatric patients, and never crushing extended-release formulations, assessed consistently for misuse. Ritalin carries a black box warning for abuse and dependence. As a Schedule II substance, patients and families must be counseled on secure storage, never sharing, and proper disposal. Dextroamphetamine, also known by the brand name Adderall, blocks reuptake of dopamine and norepinephrine while also promoting their active release. A dual mechanism that makes it more potent and faster acting than Ritalin. It is approved for ADHD and narcolepsy. Contraindications mirror Ritalin's, plus history of drug abuse, hyperthyroidism, or glaucoma. Serious adverse effects include sudden death, stroke, MI, severe hypertension, psychotic symptoms, and Raynaud's phenomenon. Commonly, insomnia, decreased appetite, weight loss, and dry mouth. Nursing priorities include a thorough cardiovascular evaluation, ongoing BP and heart rate monitoring, and counseling patients to take it early in the day. High-fat meals and acidic beverages reduce absorption. Never stop abruptly. Like Ritalin, Adderall carries a black box warning for abuse and dependence, and misuse is associated with sudden death and serious cardiovascular events. Both are Schedule II, a classification that reflects the significant risk outside therapeutic use. Atomoxetine, also known as Strattera, is a selective norepinephrine reuptake inhibitor. It increases norepinephrine availability without activating dopamine reward pathways, making it a non-controlled substance with much lower misuse potential. It is approved for ADHD in ages 6 and older through adulthood, contraindicated with MAOI use, narrow angle glaucoma, and caution warranted in severe cardiovascular disorders, or phenochromocystoma. The most critical adverse effect is self-harm ideation. The risk is highest in children during early treatment and dose changes. Commonly, nausea, decreased appetite, fatigue, and dizziness. Monitor closely for self-harm ideation. Assess liver function regularly and never open capsules. The powder is a primary irritant. Set clear expectations. Full therapeutic effect may take 2 to 4 weeks. Strattera's black box warning is for increased self-harm thoughts in children, teens, and young adults. Patients and families must be informed before treatment begins. Clonidine, known by the brand name Catapres, is unlike anything we have covered so far. It is an alpha-2 adrenergic agonist. It stimulates central receptors that reduce sympathetic outflow, causing vasodilation and lowering blood pressure. In ADHD, this produces a calming effect on hyperactivity and impulsivity, making it valuable when stimulants are contraindicated or when hypertension coexists. Used with caution in severe coronary insufficiency or impaired renal function, most critical risk is rebound hypertension from abrupt discontinuation. Commonly, sedation, dry mouth, and dizziness. Monitor BP and pulse regularly. Adjust dosing based on cardiovascular response, and counsel patients to never stop abruptly. Educate on orthostatic hypotension, and avoid alcohol and CNS depressants. Although there isn't a black box warning, rebound hypertension is a serious documented risk that must be addressed at every patient education encounter. Nursing assessment begins before the first dose is ever given. Therapeutic communication gathers a subjective picture. How the patient is feeling, their energy level, mood, and behavior. That becomes your baseline for evaluating medication response over time. Blood pressure and heart rate are established. Psychiatric history is screened, and current medications are reviewed for interaction risk. These are not checkboxes. They directly influence what is safe to prescribe. Implementation is more than just handing over a medication. The nurse ensures timing is correct. Stimulants in the morning. Extended release formulations are never altered. Patient and family education happens here, not as an afterthought. Drug interactions are monitored, responses are documented, and if symptoms paradoxically worsen, the finding reaches the provider promptly. Every one of these steps is part of a safe and effective implementation. Evaluation is not a one-time event. It runs continuously throughout treatment. Compare current findings against the baseline established at assessment. Is mood improving? Is attention more sustained? Is behavior more regulated? Patients need a realistic timeline. Stimulants may show effect within days, while Strattera can take weeks. Blood pressure, heart rate, weight, and growth are revisited at every follow-up. If the response is insufficient or adverse effects are emerging, the nurse's evaluation is what drives the next clinical decision. And throughout all of it, education is happening. Patient and family education is one of the highest impact things a nurse does, and it starts from day one. Controlled substances must be stored securely and never shared. Patients need to know which symptoms require immediate attention. Alcohol should be avoided across all 4 medications. Nothing gets stopped abruptly without provider guidance, and for patients starting Strattera, the single most important thing you can communicate is that it takes time to work. ADHD involves dysregulated dopamine and norepinephrine signaling within frontostriatal brain circuits. When that signaling is insufficient, attention fragments, impulse control weakens, and executive function declines. Stimulants strengthen both pathways and remain first-line treatment. Nonstimulants offer alternative mechanisms when stimulants may not be the right clinical choice. Nursing care extends well beyond medication administration. Assessment, implementation, and evaluation form a continuous cycle, and the patient education runs through all 3. When these medications are used appropriately and monitored carefully, they restore the functioning signaling the brain needs. And this is what this is really about, giving individuals with ADHD the neurochemical foundation to focus, regulate, and function at their best. Understanding pharmacology for elevated patient care.